Today we'll be covering Histoplasma by David, Zonka, Seth, and Amber. We'll be covering what histoplasma is, the pathogenesis and clinical manifestations of histoplasma, diagnosis and treatment, and then an overall conclusion.
So what is histoplasma? Histoplasma belongs to the phylum Ascomycota, and it is found in soil-enriched bird and bat guano. It is frequently present in the Ohio and Mississippi River valleys, as well as Arkansas. The species that encapsulates this is Histoplasma capsulatum, which causes histoplasmosis, which is what we will be talking about later, as well as Histoplasma duboisii, which is just commonly found in Africa, and Histoplasma farciminosum, which causes epizootic lymphangitis. This causes chronic skin ulcers in horses and mules, as shown on the right side photo. It is a dimorphic fungus, meaning it has two life cycles, and it affects the whole body via the lymph nodes or the blood. So it does this by producing multiple filaments called hyphae that intertwine and form a mycelium, or the mold body. This mold body releases microcanidia, which are then inhaled by humans and animals and converted into yeast form. The yeast form will then survive and replicate inside macrophages and then spread to the body via the blood. All three variants follow this. A brief history of histoplasmosis. So it was first reported in 1905 by pathologist Samuel Taylor Darling of a 27-year-old male worker on the Panama Canal, who developed a disease that spread throughout the body in a very aggressive way. In response, the patient's lungs were filled with granulomas, or clusters of immune cells that wall off hard-to-kill microbes. This caused him to mistake it for miliary tuberculosis. He then believed it was a protozoan disease before someone finally recognized it as a fungal infection. I added the first two photos at the bottom of the screen to show how similar miliary and histoplasma look. The photos are CT image scans, so you view these like you were standing at the patient's feet and looking through the head. The small round nodules or granulomas can be seen in both of them.
H. capsulatum first enters the body through inhalation of the fungal propagules in the mycelial stage. These will enter the lungs, making contact with the alveolar tissue. Once this is achieved, the propagules will undergo a morphological change into their yeast form, triggered by the optimal temperature within the body of around 37 Celsius. Here, the immune system will try to defend against the initial infection with macrophages, dendritic cells, neutrophils, and NK cells. However, H. capsulatum can exploit this response by being phagocytosed and using the intracellular environment of the macrophage to avoid the immune system and propagate to other parts of the body. Using receptor-mediated phagocytosis, as seen in Figure A, H. capsulatum will make its entry inside the macrophage. Usually, this is where pathogens will be destroyed through lysosomal activity, have its antigens presented, and activate the adaptive immune system. However, H. capsulatum has the unique ability to endure reactive oxygen and nitrogen species that are used to directly harm pathogens. It can also regulate phagosome acidification and lysosomal fusion, completely preventing it from being destroyed or slowing down the process in general. It has also been observed to regulate macrophage apoptosis. Furthermore, to survive within a nutrient-deficient environment, it finds creative ways to obtain resources, such as releasing cytospores to acquire iron, independent production of nucleic acids to build its DNA, and synthesize their own essential vitamins. All of these characteristics work together to allow H. capsulatum to survive in a harsh but safe environment for it to acquire nutrients to proliferate and disseminate throughout the body.
While histoplasmosis is most often asymptomatic, it can manifest as acute, chronic, or decimated histoplasmosis. Acute histoplasmosis occurs about 1 to 3 weeks after inhaling spores, and in general, the symptoms may mimic flu symptoms. Typically, in general symptoms, you'll see fever, chills, fatigue, headache, malaise, and anorexia. Respiratory symptoms can include cough, chest pain, shortness of breath, and mild wheezing. You may also see patchy infiltrates on the X-ray and sometimes nodules seen in A and B. One unique symptom is erythema nodosum, only seen in about 6% of cases, while most present in women. Symptoms usually resolve in several weeks and in most cases are self-limited and do not need treatment. Chronic pulmonary histoplasmosis is progressive and typically seen in patients with pre-existing lung disease or older adults. General symptoms include weight loss, fatigue, fever, night sweats, and typically mimic TB, tuberculosis. Respiratory symptoms can include chronic productive cough, hematosis, shortness of breath, and chest pains. You may also find lesions, scarring, fibrosis, and nodules on x-rays. Symptoms will last up to about 3 months and can lead to respiratory failure if untreated. It is important to note that chronic histoplasmosis is a reactive disease, meaning that spores may remain dormant in the lungs for years and later reactivate. In disseminated hemoplasmosis, this is severe and a systematic infection. Human cases are extremely rare and almost exclusively seen in individuals with severely weakened immune systems. Symptoms will usually develop weeks to months after exposure and can include a general symptom including fever, weight loss, fatigue, night sweats, respiratory symptoms of cough, shortness of breath, and rapid breathing. It usually will invade the visceral organs, liver, spleen, pancreas, and the GI, causing symptoms like anemia, bleeding or bruising, ulcers, rashes, nodules, diarrhea, abdominal pain, GI bleeding, and enlargement of the liver and spleen, and enlargement of the lymph nodes. In severe cases, this can cause sepsis, multi-organ failure, and decimated intravascular coagulation.
Diagnosis. Antigen detection via the urine or the serum is a rapid and sensitive diagnostic procedure. However, cultures of the yeast cells can also be taken. However, this is slow, oftentimes taking several weeks to propagate, and can present biohazard risk to personnel. One of the best rapid and accurate diagnostic procedures is microscopy. Microscopy is used to view the intracellular yeast in these macrophages, and there are multiple methods to do so. Fluorescent microscopy can use, and dyes can be used to highlight the chitin walls, or bright field microscopy can be used using methods such as methamine silver, which highlights the mold cell walls and the mold cell membranes, making them much easier to visualize, identify, and diagnose. Treatment. For light or moderate cases, this is treated with rest and will usually resolve itself within a couple weeks. However, for moderate, severe, even life-threatening cases, these are treated with powerful antifungal medications like itraconazole or amphotericin B. These medications work by attacking the cell membrane of these yeast molecules, causing them to become leaky to the point they eventually die. Even with these medications, infection can last a couple weeks, months, or even years, sometimes going dormant and then again returning years, if not decades, after the original infection.
In conclusion, Histoplasma is a dimorphic fungus found in soil originating from bird and bat droppings. Inhalation of these spores go into the lungs and are converted to yeast at specific temperatures, and then are phagocytosed by macrophages and disseminated to other tissues. These can range from asymptomatic to life-threatening depending on the form. You may see acute, chronic, or disseminated symptoms. Early recognition and appropriate antifungal treatment are key to this disease, and awareness of endemic areas and risk factors can help with early diagnosis and prevention.